Hi, I'm Dr. Shiloh.
And I'm Dr. Scott.
And this is LA Not So Confidential, the forensic psychology and true crime podcast.
Each week, we explore the intersection of psychology, the criminal justice system, and entertainment.
Today, our episode is on the forensic psych topic of body integrity identity disorder.
All right, everybody, welcome back. Wow, we have been on a whirlwind the last couple of weeks. As I was just saying before we started recording, I'm not even sure what day it is.
What time is it? We are recording exceptionally early today, but
For us, yeah, this is
we're
very
back.
early for us to record, yeah.
Yes,
But
good
the
to be back.
traveling and jet lag has been kind of like monumental, trying to do a work schedule. Yeah.
And get ready for the
Well,
next
that one
one.
won't be so bad.
I just packed all of our goodies for the Berkshires yesterday. I was like, okay, I have time. I'm going to make sure I got all of our stuff sorted out. We have several Patreon members coming out. I told them, hey, list off who's going for sure so we can keep it straight when we get there and maybe bring a little something extra for you guys in terms of swag. So if you are a Patreon member, you're heading to the Berkshires, make sure you go back to the post from the first week of October and let us know that you are coming.
Yes.
So very excited.
Please give us heads up so that we can pack accordingly. We've learned our lesson after doing several of these about how to really, really organize our packing. But if you're new to the show or you're jumping around episodes, this is early October 2024. We are just back from the CrimeCon UK convention. It was fantastic. It's our second one. It's a great convention. It's not related in any way to CrimeCon United States. It's a completely different entity. Not dissing on not dissing on CrimeCon United States, but UK is like a completely different feel and much more the vibe that I like, that I'm comfortable with. So it was a great experience, great exposure. Our last episode, as we were talking about, well, we'll get to that in a second. But yeah, it's been great. And we're going to the Berkshires. So please meet us there or listen in. We've got a really fun episode that we're going to generate there as well.
Yeah, definitely. So yeah, our schedule has been a little all over the place, but our last release was a bonus episode of our live recording from CrimeCon UK, in which we sort of mashed up a few different topics and we looked primarily at false victimization. And then the week before that, because we were on holiday in the UK, we released our fascinating live talk with Dr. Joni Johnston, and that was on psychological autopsies.
Yeah, what a wealth of information and knowledge and experience. And if you want to put a Google alert on Dr. Joni, please do, because anytime she's a guest on a show, it's definitely worth listening. She's got so much to offer. But our last full episode was number 190. Oh my gosh, 190 episodes on our 7th anniversary, right?
Yes,
We just had our 7th
yes,
anniversary.
we did.
We highlighted the Sandra Birchmore case to discuss sexual abuse and police explorer programs. And it was really a sobering look at yet another program for teens and children that has inevitably led to exploitation and abuse at the hands of a few predators. We're not dissing all programs. Some of these programs are absolutely vital and wonderful and kind of shape the path of children's and adolescents' lives in a wonderful direction. But of course, there are people that are unfortunately there to take advantage of our most vulnerable population.
Yeah, just another example of a job that they can weasel their way into and have access to victims. So that was a good episode with some really good feedback from folks. But today we have a whole new topic for you, and there's various psychotic disorders out there that can lead people to do some incredibly drastic behaviors based on their false beliefs. And we're going to explore whether or not this fits today. But I had gotten this idea for this episode while sort of looking over my daughter's shoulder as she was watching an episode of Grey's Anatomy. Why she's decided as a 12-year-old to go back and binge Grey's Anatomy, I don't know. I never watched it.
It's so interesting.
But she is all in. But there was a particularly gruesome episode and scene depicted in the show with a man who had body integrity identity disorder, We will, of course, cover more of that at the end of today when we talk about entertainment depictions. But, we have covered a lot of disorders of the brain that lead people to harm others. But this time, the injurious behaviors turn inward.
Right. Again, very, very rare disorder that we are aware of at this time, although the research is very interesting that shows that there is a lack of information about how many
Yeah.
people may actually be experiencing this. But we wanted to share some of the portions of a vignette from the Unusual and Rare Psychological Disorders. It is a handbook for clinical practice and research, just in order to give us an idea of the mindset of someone with BIID. And the example that they use is of a 29-year-old German male who consulted a psychotherapist for feelings of depression. And the vignette states that he told his therapist in the third session, quote, "Inside, I cannot bear it anymore. I'm lying to everybody, wearing a mask every day. If I didn't wear it, my family and friends will think that I am crazy." So the patient goes on to state that ever since childhood, he wished to only have his left leg. And he remembered playing in the garden at around 6 years old, pretending to only have the left leg. And it was not the case that the leg had something wrong with it, the right leg being the one that should be gone. The right leg simply didn't feel that it belonged to his body. So the client sought out support on an online forum before going to therapy. And then he discussed with others the possibility of removing his right leg because he no longer felt that pretending was enough.
Yeah. So as he contemplated his options, including doing it himself because he didn't have the money for the surgery or didn't know if anyone would even perform it, his depression really intensified and he started suffering from insomnia, feeling tired all the time. Additionally, he really became obsessed with the idea that he would never become happy without this modification to his body. And in the end, he decided to borrow money from the bank, telling them that it was for education. And he went through with the surgery and he decided that he was going to just tell his family and friends that he had an accident while he was on vacation and had decided through talking this out in therapy that that was going to be his story. So, really interesting just to start us off with what the mindset is for somebody experiencing this, but also the lengths that they might go to. I would say this is a great point for trigger warning because we are going to talk about self harm in a number of ways that people have injured themselves because of BIID, not because of suicidal behavior or other types of self harm that we've talked about in the past. We're going to stay away from great detail, of course, but some of them are hard to listen to and sort of picture in your mind.
Right. So let's start off talking about what body integrity identity disorder is and the number of other terms that are used interchangeably or with some subtle differences. There are some where it's called dysmorphia, some where it's called a disorder because it's not a formal, real diagnosis that's in the DSM. This is just something that is so very rare that it's still sort of in its infancy as far as like whether or not it becomes part of a larger diagnostic category. More recently, there's been another term used called xenomelia, literally meaning foreign limb. So it's considered to be a neuropsychiatric condition in which non psychotic individuals have an intense, persistent belief that one or more of their limbs doesn't belong to their body. Instead, they regard that body part as an alien appendage that needs to be discarded. And generally, people suffering with this belief are completely, and I hate to use this term, but completely normal individuals with no previous psychiatric history or other problematic social issues. And even that little descriptor right there is a little bit problematic because what is normal?
Sure.
And then what are factors that we are not yet attuned to as clinicians, like childhood development, exposure to
Mm,
images? There's all sorts of things that could happen because there are documented incidents about this as long ago as 1785 when a French surgeon described the case of an English patient who had asked him to amputate a healthy leg in exchange for payment. Once the surgery was complete and the man had recovered, he thanked the surgeon for completing the operation and reported that it finally allowed him to live a happy life. So interesting factor in that particular example is 1785, surgery was very brutal.
Right. And the
There were
surgeon's
no
like, "Okay, sounds
antibiotics.
good.
It's like
Let's do
you were
this."
literally taking your life into your own hands because at
Oh,
that
yeah.
time, the risk for infection basically was what took out tons of people that had any kind of surgical procedure. And as always in our field, we work to identify nuance and discernment in labeling an individual's experience because there's also a much different phenomenon where individuals with amputee identity disorder or apotemnophilia feel as if they were meant to be an amputee. It may sound the same as BIID, but it is not. Apotemnophiliacs do not feel like their authentic selves living fully as an able bodied person. Similarly, there are people who desire to be disabled in other ways, perhaps desiring to become blind or deaf. Some of these individuals refer to themselves as transabled. So for today, we're generally going to be focusing on BIID, but some examples will explore the other situations, especially when we look at the ethical considerations for the professionals who make the often difficult decision to assist them. And then we're going to explore whether or not that decision is appropriate as clinicians.
Yeah, yeah. But I will say, again, the limited research out there is a bit confusing. In a sense, the researchers, like you said, are still kind of developing these terms as they gather
Right.
data. So, as theories and data is in its infancy, people can kind of label it whatever they want. And then it usually takes at some point the community deciding, like, this is what we're going to call it. But David Michael First, he's a professor of clinical psychiatry at Columbia University, and he first coined the term BIID. He seems to use the phrase as an umbrella term for nearly all of the above, stating on his website that BIID is, quote, a rare condition involving a lifelong desire to become disabled, most commonly the desire to become an amputee, end quote. So that's what we have to go with right now.
Right, and I get it in terms of research. That's generally just the way that things develop. It's the
Yeah.
acknowledgement of an area of study that is needed, and then it's up to the research to continue the exploration into smaller and more precise definitions because when you first attack a concept like this, it's just so big. Where do
Hmm.
you even begin? You're gonna have to be very conceptual for a while.
Yeah, definitely. So, with that clear as mud foundation, let's move on to theories of etiology. The exact prevalence of BIID is unknown because many people with the condition don't seek treatment or they work really hard to hide their symptoms. I mean, you can imagine how taboo it would feel to experience this. So, people with the condition may avoid discussing it with medical professionals altogether and just seek out other forms of support, like doing their own research online and finding communities in that way. Therefore, estimates of the prevalence are very difficult to say for sure, ranging, and this is a big range, but this is what we have from the research, from 1 in 5,500 to possibly 1 in every 22,000 people suffering with this.
And of course, I guess what you would call the relative anonymity of the internet is going to provide an opportunity for individuals to be able to connect with each other to somewhat normalize their experience or at least realize, okay, yes, this is very strange and it's not like the general population, but at least I'm not the only one out there having
Right.
this, right?
Yeah.
And in regards to exploration of the phenomenon, it seems like the majority of the actual applied analysis has come out of that research lab in San Diego, and they've been looking at patients with BIID and focusing on their parietal lobe in the brain, specifically, actually, the sensory cortex. So, the parietal lobe is located in the upper middle part of the brain behind the frontal lobe and above the occipital lobe. It's roughly rectangular in shape and it's involved in processing sensory information like touch, spatial orientation, and navigation of the body through the world. And in BIID, essentially, that area of the brain registers no neurological response when sensations are tested on the area of the body that should register a response. So what's fascinating is that tapping or pricking the part of a leg or arm or limb that someone feels is not a part of their own body doesn't light up the brain the way it's supposed to. So some people might recall from high school biology, or if you've been in a graduate program, what's called the homunculus image that we've covered in the past in and also in all of our neuropsych courses. So it's this image that is very cartoonish, and it's a picture of the brain with different body parts outlined on the outer edge to represent how our sensory system is laid out. And if you're interested, just Google it right now. It's called the homunculus image, and then put in neuropsych. And the image that comes up is pretty wild. So it shows how the sensory system is laid out for our entire body. It's kind of creepy. It's a distorted view of the human body. Anyway, the system tells you where your body begins and ends as far as perception. And the research from San Diego is seemingly illustrating that some people's brains are telling them that their body part just isn't there. The research is absolutely compelling, and it has very suggestive evidence, but it's not a complete conclusion that's totally neurological, although it seems to be the leading theory at this time.
Yeah. So, I think we wouldn't have included this as an episode if it was just purely neurological necessarily. There is some available research out there that shows that, well, they know that onset for BIID is pretty early. So once folks do find themselves talking to medical or mental health professionals, they do report that they have felt this way really since childhood. But I think it's really compelling to look that there's even some very specific research that shows that many of these individuals had childhood friends who were disabled or who were amputees, and that they had overwhelmingly positive feelings towards those friends in terms of admiring them for overcoming challenges and kind of viewing them as just like otherwise healthy in the way that they live their lives. I find this super fascinating because I think it works against a purely neurological explanation, at least with those folks that are reporting this. And it might be something more linked to our personal experiences. But the overwhelming majority of individuals with BIID are male. 80% of them are male. Most are Caucasian and have a university degree or higher education. The average age of people with BIID is around their mid 40s. But again, I think we can safely state that this is when people might tend to seek treatment, and they're probably experiencing it for much of their life prior to that time. The documented onset for desires or wishes to amputate parts of their body start between the ages of 8 and 12.
So, the long and short of it here is that there's no cure currently for body integrity identity disorder. The most common psychiatric symptoms are severe depression and anxiety, and these may result in self harm that are aimed at getting rid of the limb or resorting to injuries that make the limb die. It's not uncommon for people to submerge their limb in dry ice or to induce frostbite so that medical services will have to amputate it. The most common types of therapy suggested are group therapy sessions, cognitive behavioral therapy for treating depression, anxiety, and obsessions, and then pair all of that with antidepressant medication. That's generally one of the most successful ways you treat any psychiatric issue is with medicine and one-to-one behavioral or talk therapy. And it's similar to how we've talked about treating delusional disorders in the past. So the focus is on the very real mood disorders that arise because of this neuropsychological disorder. So not saying that this is a delusion, but their belief and physical lack of feeling is very real to them.
Yeah, so you're going to treat the anxiety, treat the depression, regardless of what is causing it, of course. And, I think the CBT could be really effective for the obsessive thoughts as well. Because some people might decide not to go through with it, but they're learning how to live with the fact that they have
To
this
cope.
limb that they
Yeah.
don't want. Yeah, yeah. Alrighty, so let's talk some ethics here, because if the person with body integrity identity disorder wants to do something about it without taking matters, I guess, into their own hands per se, they're going to seek out a medical professional to possibly amputate their body part. But let's see what the given research even says about whether or not that type of surgery would be worth it. The primary rationale given for individuals suffering from this, for their desire to get the body modification, is to, quote, feel complete or to feel satisfied inside. There is indeed a 70% success rate of, quote unquote, resolving BIID when they do undergo surgery. And Dr. Chris Ryan, a psychiatrist out of the University of Sydney, says, quote, people who have amputations usually say they only wish they had done it earlier, end quote. So this psychiatrist, he has consulted in about 10 cases globally of BIID. He gives some valuable perspective in a particular documentary that we will also refer to later. But he says that people with BIID feel that some part of their body isn't theirs. They know that it is, but they feel that it shouldn't be. They feel this intensely, and the ongoing presence of that part of their body is very distressing. He goes on record to say, I'm pretty clear that it's almost certainly a neurological disorder. It sounds very neurological because we know that there's a system that tells us where the body begins and ends. And it seems like this is a malfunctioning of this system. So, Dr. Ryan, interestingly, he says that in his experience and what's backed up by the literature, that it's more common in legs than arms. It's more often the left than the right side. And the striking thing is that all people that come to him, again, he uses his term, are normal people. So for him, meaning there's nothing unusual about them except to say that they really, really feel a need to have an amputation because it's so unpleasant for them. So they, again, not a history of psychiatric issues, seemingly having, normal relationships with folks, not even, and I think we talk about this a little bit later, but not falling into, anything like a paraphilia where there's like a sexual attraction connected to this. Cause I think some people go that way because there's definitely, we know there are paraphilias for folks who are attracted to people who are amputees, but he's parsing all of that out. He's saying this is not part of that at all. And he goes on to say that we've tried everything at times that we could, very short of the amputation, that might be useful, because he says, look, this is a really big step. And many surgeons, rightly, aren't going to amputate someone's arm unless everything else has been done. So he stands by the fact that everyone that he has met that has had an amputation says, again, I only wish I had done it earlier. So I think this is one doctor's perspective and experience, but he's not seeing regret that I'm sure our listeners are thinking about. How do people feel on the other side of this? So at the end of it, the research is showing, again, a 70% success rate of resolving it. But what about that 30%?
Yeah, 30% is not an unsubstantial
Right,
amount. It
right.
really isn't. I would say also that Dr. First interviews very well. He's clearly very knowledgeable. He's clearly very dedicated to getting to the root of this. And one thing that I'll notice in the research and in the interviews that we watch, there are several YouTube videos that we are pulling from, you'll see in our notes, that I encourage people to go and look at, is that, and while I am happy for people to pursue their sense of completeness in a healthy way, I would say that several of the people that are interviewed are eccentric. And I'm not
Sure.
going to make any kind of diagnostic implications. I'm going to say these are eccentric people. Now, are they eccentric because they've lived with masking for BIID for their entire life, and
Perhaps.
so their personality has had to adjust because of this? Or is that eccentricity indicative of something else that's going on? And that is something that I think is not necessarily addressed in the current literature that I have found, because it's a nuance,
Yeah.
right?
Yep.
Because he's saying all the people that come here are normal. Well, what does that mean to you? Does that mean that they're able to look you in the eye when they talk to you, and they're okay with shaking hands and sitting down and being very open about their experience? I don't know what normal means to him, right?
Sure.
So, as our listeners, you're probably wondering, what is the crime here? Why is this topic being discussed on a true crime podcast? And you'd really have a point, because on one hand, a treating physician, a psychiatrist, a therapist, they're there to help an individual reach, or at least strive in the direction of that client's highest level of functioning. But the issue here requires more of a nuanced discussion, because the philosophy of medical doctors that emerges from the Hippocratic Oath is, first, do no harm. Luckily, there is research and exploration of that very factor. And in this article entitled No Harm, No Foul: Body Integrity Identity Disorder and the Metaphysics of Grievous Bodily Harm, by Richard B. Gibson, and it explores the ethical and legal dilemmas that are faced by doctors when treating patients with BIID. So, as we've presented, the literature shows that the mismatch of body composition versus how the patient believes that they should be constructed can cause severe emotional distress. And some individuals believe that amputating the limb is the only way to find relief.
And this raises both legal and ethical challenges. In countries like England, doctors who perform amputations on healthy limbs might actually face criminal charges for grievous bodily harm under the Offenses Against the Person Act of 1861. This law is designed to protect people from intentional harm, and amputating a healthy limb could be interpreted as causing harm. Aside from the squeamish factor that one might experience thinking about this disorder, and that would be normal to have such a reaction as someone who does not experience BIID. At the heart of this issue is the question, what does harm really mean? For the law to apply, harm must be caused, but there's no clear definition of harm that everyone agrees on. Again, a very, abstract term in a lot of
Right.
ways. Some might argue that losing a healthy limb is obviously harmful, while others might say that if the person feels better mentally and emotionally afterward, then it's not really harm at all.
So, in that article, Gibson discusses three different ways of thinking about harm to better understand whether BIID related amputations are harmful. So, the first one is called the counter temporal model. And this model looks at whether the person is worse off after the amputation compared to before. If the surgery leaves them in a worse overall state, then it might be seen as harmful. But if their well being improves, like if the surgery reduces their emotional suffering, then this model might suggest that no harm has been done. But then there's the counterfactual model, and that compares the person's current state after surgery to what it would have been like if the surgery hadn't happened. So they're looking at if they would have been better off without the surgery, then harm might have occurred. However, if surgery improved their life, this model would likely conclude that no harm was done.
And finally, the non comparative model. This model looks at whether the person's condition after the surgery is inherently bad without comparing it to any other state. In other words, is being an amputee harmful in and of itself? This model tends to rely on general social norms, which often view having all limbs as the ideal. But this can be problematic because it doesn't consider individual experiences, and not everyone sees physical impairment as harmful in the same way. So Dr. Gibson applies these models to the case of BIID and argues that amputation might not always cause harm, especially when it brings significant relief to the person's mental health. Many BIID patients report feeling much better after amputation with reduced distress and greater happiness. And for them, the psychological benefit of having their unwanted limb removed seems to greatly outweigh the physical consequences that they now have to learn to live with. The article also touches on the broader ethical questions raised by these cases. The law tends to assume that harm is clear cut. But in cases like BIID, the definition of harm just becomes more murky. And Gibson suggests that the legal system needs to be more flexible in its understanding of harm, especially when the goal is to relieve psychological suffering rather than address a physical illness. I think this is really interesting in terms of just like how we think about suffering. And, you and I are probably spending much of our time, especially when we're trying to normalize therapy for folks of like, hey, if this was a physical injury, you would go get it taken care of.
Right.
The mind body connection is just what's like rising to the top for me in this whole conversation. But Gibson also argues that doctors performing amputations on BIID patients shouldn't automatically be seen as committing grievous bodily harm in cases where the surgery brings psychological relief and improves the patient's overall well-being. It may not fit the traditional definitions that we've created for harm. And the article calls for a more nuanced approach to understanding harm in medical ethics and law, especially when dealing with complex conditions like BIID that challenge conventional views of health and well-being. I'm sure this guy has talked at like conferences and conventions. This would be a fascinating talk to go to and just to hear the audience's reactions and where that intersection of medical ethics and law, where people are at with it.
Yeah, that would be absolutely fascinating. I think also just for people that are listening, I know that we're really heady and heavy right now on the research without even giving you like we gave you like one little bit of a case at the beginning, but definitely hold on like because I know we're coming at you with a lot of intense, dense information, but the examples that we have are really challenging and they're part of a conversation that it's really brought up a lot for me. I'm not
Yeah.
going to say I was triggered by any of this, but it really made me think about the concept of suffering,
Mm,
um, and
sure.
suffering in ways that are just completely alien to your own personal understanding, and how there's an intersection between that a lot of us feel in certain ways. So, if you're getting squeamish, I completely understand, but bear with this because there's some interesting conversation to be had. So there is research out there that while it needs to be more profound and better constructed, it is exploring these various aspects of BIID. So it's not just looking at one factor, it's looking at the neurological, the psychological, and the social aspects of those individuals that are experiencing this desire. And in another article entitled Lower Limb Parapersonal Space and the Desire to Amputate a Leg, the researchers examined the role of what is called peripersonal space. And that refers to the actual physical space around the body in which our multisensory integration occurs and in individuals with BIID. So, this research examines how those individuals diagnosed with this perceive and interact with the space around the limb that they desire to amputate. And some fascinating stuff has come up from this.
Huh.
So, the research shows that people with BIID show an abnormal physiological response to stimuli approaching the affected leg, but normal responses around the unaffected leg. So, just in layman's terms, it's like they're more hyper aware of anything coming in contact with the limb that's not supposed to be there. But the study found no significant difference in the size of parapersonal space around the affected leg compared to controls. The paper also suggests that while individuals with BIID feel disownership of the limb, the neural mechanisms that are responsible for protecting the body and space remain intact. So
Wow.
while it is a neuropsychological issue, one part is working as it's supposed to work, and the other part of the brain is not working the way it's
Huh.
supposed to work. So this
Yeah.
research offers really a much more solid neuropsychological perspective, and it highlights the retained function of peripersonal space in these patients despite their desire for amputation. So it suggests all of this research is kind of suggesting that BIID is more about a misalignment of body representation rather than a failure in neural protective systems. Isn't that
Wow.
wild?
What a nuanced way to study it.
Yeah,
It
to like
uh,
really dig down into that one area. Let's compare these two mechanisms within the brain.
right, like, you don't even feel like this is a part of your body, yet you feel or are protective of this personal space that surrounds that limb.
Exactly.
Wow. Yeah, I'm sure that as a neuroscientist, I'm sure that is very, very meaningful. I don't know exactly what all it means, but yeah, just a holistic way to start looking at this phenomenon. So, in the article, apotemnophilia, body integrity identity disorder, or xenomelia, psychiatric and neurological etiologies face each other. That was published in the Journal of Neuropsychiatric Disease and Treatment. The focus was on the psychiatric and neurological explanations for BIID, and it contrasts psychiatric views, which frame the disorder as a form of sexual or psychological disturbance, with more recent neurological perspectives. So, again, everything that we've kind of defaulted to in psychiatric diagnoses or exploration of anything with this has usually focused on the paraphilia part of it. So, with neurological studies, they argue that BIID may stem from disruptions in body representation, which is, I think that's a good overall term for what you were just talking about with that personal space. And I have a lot to say about personal space just in general.
Right.
There are definitely people with some sort of disorder that don't. don't know about other people's personal space. But yeah, how people sort of neurologically perceive their body parts. And the desire for amputation or paralysis is seen as a way to restore a sense of bodily completeness rather than anything having to do with sexual arousal. And this article critiques the traditional psychiatric views and argues for a more integrated approach that considers neurological and psychological dimensions, suggesting that neither etiology fully explains the disorder. Again, calling for just sort of multidisciplinary research, which I think is always great to include, because I do feel like if somebody does decide to move forward with a amputee surgery, that again, to use the term, like this should be a holistic multidisciplinary team that is involved, including a mental health professional, not just on the front end but on the back end, right? Like how are they going through this giant transition in their life? And I think something that we didn't bring up is, what if the surgery goes wrong? That is one of those risks. I mean, I know it's a risk with any surgery, but what if something goes terribly wrong during the surgery and they are like physically worse off than they were before in ways that weren't even thought of, infection or what have you?
No, and yeah, I think that's a good point. I would surmise, given not that I've worked with anyone with BIID, but other people who are very invested in trying to live their lives in an authentic way that is representative of who they are. They want the outside world to see their inside view of themselves. And I think that for many of them, well, it's not that I think it, I know this as a clinician, that it's worth the risk.
Sure. Oh, sure.
That for many, it's just worth the risk because there's a buildup of pressure when you are not aligned with how you want to walk through the world that
Yeah.
can be emotionally overwhelming to the point where there is no quality of life, right?
Right. Right.
So that's probably a big factor in this. And then there's another scientific view that we wanted to offer that was from an article in Frontiers in Psychology. And that article is entitled Xenomelia, a Social Neuroscience View. And it explores BIID from a social neuroscience perspective, integrating neurological, psychological, and social components of body self-consciousness and how that can contribute to this condition, which this is the part that this is one of the ones that I really, really liked. So xenomelia is another sort of name for BIID, but it uses other sort of terms that are like a little more adjunctive science in that they say it's a disorder of bodily self-consciousness. So, and then go on to like further define, say that individuals fail to accept one or more of their limbs as part of their body. That then leads to the desire for amputation or paralysis. So, this model emphasizes the intense impact of social factors, which will also include things like cultural attitudes towards disability and bodily norms for that culture and how that may influence how individuals with this disorder perceive themselves and their limbs. And so this perspective argues that bodily self-consciousness is shaped by a combination of both neural circuits and social context. And it's saying that, like, hey, you can't look at this disorder just through a biological, neurological lens. It's not
Right.
possible to do that, which I think is important. I don't think it's necessarily always valid in every study to look at this factor, but in this one, I think it is very important because the implication here is that social neuroscience views will be able to broaden an understanding of this disorder by incorporating all those factors that affect the self consciousness. And this contrasts with all the previous ones that we talked about that are purely neurological or psychiatric explanations. So it's emphasizing this dynamic interaction between brain, the sense of self, and the surrounding society. So all three of these articles agree that the desire for amputation in BIID patients stems from a mismatch between their internal body image and their physical body. However, the first article leans towards physiological responses from multisensory integration. The second looks deeper into psychiatric and neurological origins, which moves away from sexual motivations, which is what we want to do. And then the third one offers a more holistic, interdisciplinary perspective.
Yes.
So we
Wow.
yeah, we wanted to give you a couple of cases, and these are absolutely fascinating. Totally fascinating. The first one is Chloe Jennings, and she is a woman that is living with BIID, and she spends most of her days, whenever possible, in a wheelchair, even though she can physically walk, hike, ski, and engage in all the activities of daily living as a fully abled individual, which she currently is. And this is an unusual situation, and it's featured in a video by the YouTube channel Truly. Truly has over 10 million subscribers. They do really interesting, very interesting content like this. They don't do it in a salacious manner. They're very respectful. So we're going to put a link into it in our show notes. Chloe's life, by her own admission, has been shaped by her desire to be paralyzed. And that's interesting because being paralyzed would clearly make it difficult for someone to live in a world that is designed for able bodied people, right? But it compels her to live as if she was paralyzed, although she is completely physically healthy and mobile. Chloe is a Cambridge educated research scientist, and she will readily admit that she's gone even as far as hurting herself in an attempt to make her desire for paralysis a reality. She's even stated, I have fantasies about having a car wreck and becoming paraplegic from that.
Yeah, although Chloe wishes she were paralyzed, she does still enjoy sports like skiing and hiking. And when skiing, she readily admits to engaging in the activity in a very aggressive and extreme manner. Despite wanting to be paralyzed, she says she enjoys skiing. She's even quoted as saying, skiing is essential to me and it helps me cope with my BIID. I ski very aggressively, and if the trail is smooth, I go as fast as possible. My friends and family worry about me because they know that I want to get injured. So she's using it as a coping mechanism, right? Like any of us would use a physical activity to deal with some of our emotionality, perhaps. But there's this other side to the coin where she's like, well, if I ski aggressively and get paralyzed, so be it. Again, going back to, kind of the ethics of this, what if she gets into an accident and it's not that she's paralyzed, right? It's a head injury or something else,
Or injure someone else.
or injure someone else. Yes, really, really good point.
And I think that that is what makes this particular example different from many of the other ones out there is
Uh,
I definitely appreciate the authenticity with which she describes what she's going through.
yeah,
But these two examples that she uses, skiing very aggressively, there are other people on the slopes, right?
very true. Very true.
Driving, you're
Yes,
there are other people involved in driving in that. And now, but again, like I said, I really appreciate the authenticity and the clarity with which she is sharing her challenges. But this is another one of those where you're watching it and it's like, well, there's an eccentricity here that seems parallel to, but separate from the
sure.
BIID. But I'm
Yeah,
also not her clinician. She has a clinician that she's working with, and they probably will have more insight, right?
for sure, for sure. So Chloe's actively, well, at the time of this documentary, she was actively seeking a surgeon who could perform a procedure to paralyze her. She explains, quote, I found a surgeon in another country who would do femoral and sciatic nerve transections to paralyze my legs. It would cost at least $25,000 and I don't have the money for it. That's the only reason I haven't had surgery yet.
So, as a clinician myself, working to understand the very wide spectrum of mental health and emotional health challenges, I do see some immediate problems with this beyond what I pointed out earlier. First of all, how assured are you that a doctor will willingly engage in this procedure, will also engage in equal effort to maintain your overall health?
Like follow up wise?
Right.
Yeah.
Because it's such a severe, you're asking someone to do something that is so severe, will they follow up with you? That's just a question that sort of hangs over as I talk about this, which is very interesting because I'm like now thinking about my own processes and creating
Hmm.
this content, right? Because I'm a clinician. One of the things that this documentary does very nicely is that they really don't judge it. And here I am from my clinical stance is going to come across as very judgy. And perhaps it is, but I'm hoping that our listeners are seeing that it's coming from this clinical perspective of do no harm. What are the repercussions? What are you doing for your future self? And again, I understand that that is within the individual's perspective. They have a perspective that I cannot relate to at all.
Right.
So I
Well,
want to be
and
very
I
clear about that.
I don't think you're being judgy at all. I think this is what we would do clinically is if we think up potential problems or obstacles down the road, we would pose that to our clients, right? Like throw that back into their lap for them to think about, to discuss, to ponder, to talk out loud with us
How are you going
about.
to navigate this? Yeah.
Right, right, right. Not like it's not judging how she's choosing a doctor. It's have you thought about these things? Have you thought about this in a holistic way with working with a mental health professional that who's going to be on the back end of this to help you through? Right. So I don't think you're being judgy at all.
Okay. Well, thank you for that perspective. It's this is what's interesting about this discussion
Yeah.
is how challenging this particular disorder presents, right?
Yeah.
So Chloe does admit to a lifelong struggle with this desire to be disabled. And she goes on to say, when I was about 10, I started bandaging my legs when I was home alone so nobody would know what I was doing. I even made a fake leg brace to keep my knee from bending. Walking like that made me feel, wow, this is how it's supposed to be. When she began using a wheelchair full time in 2008, she found some relief from the stress of BIID. She goes on to say, the stress of BIID is intense. When I told my first few friends, I would be shaking and crying because of how emotional it was. Before using the wheelchair, I wasn't living a normal life. I always felt like I'm supposed to be paralyzed. So Chloe regularly engages in therapy with her psychologist, Dr. Mark Milan, and she does this to manage the anxiety that she experiences that is caused by BIAD. She states, people often misunderstand BIID. They think that I'm doing this for attention or disability benefits, but that's not true. In the video, Dr. Milan is interviewed as well, adding that BIID is a real psychological disorder where people want to lose some ability that they have, like the ability to walk.
Interesting. He used the term psychological disorder.
Yeah.
But so the disorder leads Chloe to constantly imagine ways she could become paralyzed. She says, I have to admit, whenever I'm driving, I imagine accidents where I'd end up paraplegic. And in 2009, Chloe survived a serious car crash when her car rolled over at 75 miles per hour. Afterwards, she wondered, did I do this on purpose to become paralyzed? Her behavior has caused concern for her friends, including a man named Dave, who's a hiking partner of hers. He says it's scary for all of us. She could die doing some of the things that she's done in the past. Even though Chloe loves skiing and faces the challenges of using a wheelchair, she remains determined to have the surgery that will permanently paralyze her. She says, quote, when I have that surgery, I know it will be the happiest day of my life.
Okay. So again, just more and more
Reactions.
reactions and complexity. But some of the notes I want to share, they give her last name, they give the full name of the treating clinician. He presents really well, he's very professional. But I want to note something that from the B-roll footage, and B-roll footage is the secondary footage that's shot in any kind of documentary or movie or television where there's a voiceover or a narrative where you need a particular image of an area or people or a setting. And it's sort of filler video footage while there's audio going on. So this B-roll footage that's used in this is that it is clear that Chloe is a resident of Southern California. Like immediately you recognize the terrain if you live here. And I recognize it immediately because I had worked in that area at one time. It's a beautiful semi-rural area that has access to many, many outdoor activities. And it's just about, I would say, like 35 to 45 miles outside Los Angeles. And as someone who presents as being from the UK with sort of a mild British accent that either
Mhm.
has faded over time. I would say this in the documentary section is that her accent is not consistent,
Okay.
which is just interesting to me. That's something that I've
Yeah.
always been interested in. I love accents,
And
but
she
it
was Cambridge educated, right?
right.
That's
So
it,
that
okay.
indicates that she's been here a long time. This is 2009, 2008 or some of the dates that they share. So it's been a while, right? It's interesting. She's coming from a country that has universal health care.
Mm.
So I'd be really concerned about her being disabled in a medical environment that may not follow through on the care that she would need. And I mean, I'm just going to admit here, I'm so ignorant. I'm wallowing in my ignorance because there are so many unknowns. I mean, here in the US, while we have incredible, incredible rights and we have great programs and abilities, we are also a huge country, and medical insurance and medical care is not consistent across our country.
No, very
Even in
true.
Southern
Yeah.
California, where we have the ACA and we have some really great programs, like I would be really concerned. Private insurance companies are brutal. They are really
True.
brutal. So,
Yeah.
like, they could come along and say, "You wait, you did this to yourself?"
Yeah, true. I mean, I don't know. Maybe I'm sure she probably lives here for work. If life leads you to certain places and you happen to have something going on like this disorder, then maybe you just got to work with what you got wherever you are. Not that she like left the UK to come here to now explore surgery. That definitely wouldn't make sense. But I don't know. Maybe she's originally from here and then spent a lot of time in the UK and picked up
And
an
then picked
accent
up
and went to school there. And I don't know.
right, and again, it's like her considerations may have a completely different context globally than mine are, so
Hmm.
completely wanna
Hmm.
recognize that.
Yeah, but super interesting. Yes, I'll put the link right in the show notes so you guys can look up this video, as well as another one from Truly. So this is a case about a young woman named Jewel Shooping, and she made a drastic decision to blind herself on purpose, though she explains that it didn't feel like a choice to her. So she speaks in this video about her experience living with BIID in this form of desiring to be blind. She says most people would see going blind as a nightmare, but for me, it was the fulfillment of a lifelong dream. She felt isolated growing up, struggling with a lot of her thoughts about this. And she says when there's nobody around you who feels the same way, you just start to think that you're crazy. I don't think I'm crazy. I think I have a disorder, she says, and kind of clarifying how she's come to understand her BIID diagnosis.
So back in 2006, she made the extreme choice to blind herself, and after researching methods, she opted to use drain cleaner, and drain cleaner is common household cleaning agent found around the world, I'm sure, certainly in the US. Most common drain cleaners contain chemicals like sodium hydroxide, which is lye, or sulfuric acid, and they work by breaking down organic material through chemical reactions. When these chemicals come into contact with water, they create heat and initiate a process called hydrolysis, which dissolves grease, hair, and other obstructions in pipes. This packaging for any type of drain cleaner strongly warns of the significant dangers and exposure to any skin surfaces, particularly mucous membranes such as eye tissue. Jewel found this to be a viable option to carry through with her plan. Now, here's where there's a significant turn as compared to Chloe's story. Jewel then found a psychologist who was willing to help her. They spent 2 weeks ensuring that Jewel was ready, a whole 2 weeks
Oh my God. I'm just
ensuring that
like,
Jewel was ready.
what? 2 weeks? Was it every day, every hour for 2 weeks? Because,
Even
oh my
so,
God. Oh my
even so,
God.
like clinically speaking, I mean, you make a
Cringy.
really great point, but clinically speaking, we look at therapeutic treatment and recovery and reconstitution and finding, your balance again. It is a long process as you are breaking down emotional foundations and then rebuilding them.
Yeah. And
I
it
don't
gets
think
worse.
I don't think there's a lot that can be done, even if it was 24 hours a day
I
in
know.
2 weeks. But they spent 2 weeks and then they carried out her plan. And she's quoted as saying, "He dropped 2 drops of drain cleaner into each eye. My eyes were screaming, but all I could think was, I'm going blind. It's going to be okay.
So, after a half hour, the psychologist drove her to the hospital where doctors tried to save her sight. Although initially upset that she could still see on the following afternoon, her vision gradually deteriorated over the next 6 months. She said, I was so happy when my sight faded away. I felt like I was finally who I was supposed to be. Despite achieving her desired outcome, Jewel's actions had severe consequences. She lost her relationship with her family. But for Jewel, this was something she felt compelled to do from a very young age. And she said, when I was around 6, my mother told me that staring into the sun would make me blind. So I stared at the sun for hours. Even though becoming blind was a difficult decision, by the time she was 21, Jewel just felt it was impossible to avoid. It was a nonstop alarm going off in my head, she said. In the video, Dr. Michael First, that we've referred to before, acknowledged the seriousness of the condition. He said many people live with these feelings without acting on them, but a significant minority feel so strongly that they take steps to actualize their desires. Our goal is to reduce suffering, but the ethics of making a physically normal person disabled is very complicated. If you consider it a treatment for a disorder, an argument can be made, but it's still a drastic move. Okay, psychologist putting drops in her eyes.
Yeah, I mean,
I
clearly you
can't.
knew I was gonna be really triggered
Yeah.
about that. Like that, I will fully admit I am completely triggered. So let me pull out my little soapbox here in my
We
closet
need a
at home.
scraping sound of your box coming out.
Yeah, like, oh, don't talk about my box.
Do you
But
keep
this
your
does
chapstick
really
in there?
raise I know, really. This raises a lot of ethical concerns about the psychologist and that psychologist's actions. While I wanna make room for having a thoughtful and understanding discussion of the individual's experiences and challenges with this disorder. I wanna be very clear that assisting a person in physically harming themselves goes against standard medical ethics and mental health practitioner ethics. So, clinicians are generally expected to prioritize patient safety and health. So, an individual who is not a medical professional aiding Jewel in her decision to blind herself would be seen as a really serious violation of these principles. I mean, serious.
Yeah.
The role of a psychologist is typically to explore less destructive ways of managing a condition like BIID, like therapy, and to ensure that a patient's physical well-being is protected on the most basic level of legality. A psychologist is not a medical practitioner, and this, for want of a better description, this injury to achieve a desired outcome is outside the scope of a psychologist's practice,
Yes.
clearly. So scope of practice refers to specific tasks, responsibilities, and procedures that we as licensed professionals are legally authorized to perform based on our qualifications, our training, and our certification. So scope of practice defines the boundaries in which I, as a professional, and doctors, nurses, other therapists from any discipline can operate safely and effectively. And this is ostensibly to ensure that these professionals work within their expertise to protect public health and safety. So we're going to go back to Doctor First because he's kind of the main guy on this and he's so well spoken. And he does express concerns about the potential for regret. The big fear is that someone becomes disabled and then changes their mind. So Jewel, at least in this video from 2015, has no regrets and she's open with her friends about her decisions. She has many friends within the blind community who take part in this documentary. And one of them, Mike, supports her, saying, I told her I didn't care. There's no resentment for her taking her eyesight voluntarily. That's just not who I am. Other friends like Debbie and Alan also admire her for overcoming so much and contributing to the blind community, which I think is beautiful and wonderful. I don't
Yeah.
know if that would be a universal response from other differently abled members of any community.
Yeah. Yeah, for sure. And Jewel hopes that by sharing her story, she can raise awareness about body integrity identity disorder and help others with the condition. And in an interesting turn, she offers, quote, if someone out there has the same feelings, I would say, don't go blind the way I did. I know there's a need, but maybe someday there will be a treatment. If you feel you have to, at least talk to a psychiatrist. Don't do it yourself because it's dangerous. That's
So
really
for
interesting
It
for
is
her to
interesting.
give that advice.
Well, it just seems like there's some good insight there,
Yeah,
that there
yeah.
really is. I think it's very interesting. Just going back to my rant, it's interesting that they only mention that psychologist like briefly. Like, yes, I had the psychologist that did it for me. I mean, even if it was a psychiatrist, a medical procedure is not within the scope of practice of a practicing psychiatrist. A psychiatrist makes the choice as a medical doctor to move their career in a certain direction, and they may have had one rotation in dermatology and one rotation in surgery and one rotation in podiatry, right?
Well,
And
and
then
it's
they decided psychiatry is going to be my thing. But then
I
you leave those behind you. You understand that, like, oh, I need to be aware of, if I prescribe this antipsychotic to a person with high blood pressure, how are we going to mitigate the problems there? But this is way outside that. If it was a psychiatrist and it's not listed as a psychiatrist, it's listed as a psychologist.
I think we're going pretty far in saying this is even a medical procedure. You're putting Drano into an eyedropper and then dropping
True.
that into like it's pretty bare bones barbaric. It's like what you thought up you could do and get away with in the privacy of perhaps a psychological office. And then you're going to have this plan of like, well, I'll just drive her to the emergency room. Like all of that just I don't know. I think she says that she found the psychologist in Canada. Not that that means anything, but it made me think that she had to kind of like, if she lives in the US, had to go to Canada to find this person that would do it. But I just, I don't know. I'm sure that person was either terrified that she was going to be talking about this in a documentary, that they would be found out, or I wonder if there was any repercussions afterwards. And then how intertwined are you with your client that you're willing to risk this? Or is it out of really understanding her suffering and wanting to help remedy that, which still crosses a line that you can't cross? Like it's not your lane. It, like you
It's not
said,
your
it's the
lane.
scope of practice is what we say, but it's not your lane.
And also, they talk about the 2 weeks of really working. Was that the length of the therapeutic relationship? Or
Oh God.
was this a 10-year I mean, not that it makes any difference, even if it was a 10-year relationship or a 20-year relationship, it's still well outside scope of practice.
Yeah, I it just can you imagine that that person even consulted with anyone else? And if they did, like really this is what they came up with? So, I don't know.
Well,
Lots
yeah,
of
I mean,
problems.
again, it seems like in this particular case, so we've given so far 2 cases that didn't actually have to do with the amputation of a limb, but there
Correct.
was the desire to become paralyzed, there was the desire and the completion of becoming blind. But Doctor First, in one of the other documentary segments that Truly has posted, uses an example of a young man in Australia who had BIID regarding one of his hands.
Right.
And it had been lifelong, and he just didn't feel like the hand was part of him. It was alien. And he had gotten so desperate at one time that he, attempted to remove it. They don't fully say what his treatment protocol is or whether he moved forward with that desire, but that is a big deal. And it would be interesting to talk to some of the people that have gone through it, if they wanted anonymity, but people who have been successful. And let's look at all these factors. And then let's look at the control group or the
Right.
people that weren't happy with the
Right.
outcome. But I think that one of the things that the research is not looking at is that they are looking at the discomfort within these individuals, and they're looking at the factors of how long it's been there, how they felt about it, how distressing it is to them. But I'm not seeing any data about the psych batteries that were or were not implemented on these people.
Mhm.
There's
Mhm.
a really, really great statistically and treatment validated modality called dialectical behavior therapy, and it's very successful for certain personality disorders, but it's also great for chronic anxiety. It's
Yeah.
like can create this foundation of like finding yourself within the world around you and how to cope and really changing your perspective on things. And I'm just not saying that DBT would be appropriate for all of these people with this particular disorder, but there's no research out there about what has been tried otherwise. Now, and would that work if we're looking at it purely from a neuropsych perspective? I don't know, but what's going to happen? I think Jewel actually makes a really good point. Is like there may be a treatment for it at some point. Like
Right.
what if there's a stem cell treatment or an ECT treatment for stimulating that part of the brain that
And wake it
suddenly
up.
turns on the awareness of the limb?
Yep. Yeah. Yeah, exactly. Interesting stuff. So let's get into our media depictions. Back to Grey's Anatomy, season 4, episode 5. It's called Haunt You Every Day. This was their Halloween episode. In this episode, a man named James comes into the free clinic associated with the hospital in the show. And this is on Halloween. And he is standing there in his business clothes and he has a foot that is just kind of moving wildly. Interesting choice for them to kind of make this more visual, I guess. And he kept saying that the foot didn't belong to him and that it felt like a corpse foot. So, kind of this language that it's dead. He demanded that a doctor amputate his foot, but because it was otherwise healthy, Dr. Bailey refuses and kind of puts him on a bed while she's waiting for the psychiatrist to come in. And she has that psychiatrist consult on the case. And he says James has body dysmorphic disorder. No, that's
No.
not what's going on here, but suggests that Dr. Bailey prescribe him anti anxiety meds and just kind of kick him loose. And so she tries, but then James insists that they aren't going to work on him. And they kind of like leave him. And they have another patient that comes into the clinic that's dressed as, the serial killer with his costume. And he has a chainsaw that gets left unattended in the clinic. And guess what? All of a sudden, they hear the chainsaw going, and James is using it to cut his own foot off, blood spraying everywhere. And his foot wasn't salvageable. So Dr. Torres agrees to complete the amputation and he's taken into surgery. My thought is, why does this guy have a real working chainsaw as part of his costume?
Well,
Hello?
because there's a lot of dumbasses that end up during Halloween in the emergency
In the
room.
ER.
Right.
Oh my gosh.
I would
Yeah.
say also, like, this is one that maybe, and what year was this? So it's season 4, so that's,
Oh
like,
my
over
God.
15 years ago because the
Yeah.
show's been
Yeah.
on for forever,
Yeah. It's
but
like,
they didn't even really consistently get it right because, a again, like we're talking about BIAD, is it's the feeling that it's not supposed to be there, like, this
right.
is not supposed to be there, whereas he's saying that it feels like a corpse foot, which is very different. That's actually probably a little bit more descriptive of a very, very rare disorder called Cotard syndrome, and
Mm-hmm.
Cotard syndrome is where an individual becomes convinced that they're actually dead,
Right.
and not like they're a vampire or that they're a zombie, but that their body is actually dead,
The
and
physical
they are just
body.
sort of mobilizing it every day. And then you're right, it isn't body dysmorphic disorder, but again, it's television and that's something, it's meant to be wild. And of course, that was the Halloween episode. So of course they want a big
Yeah.
blood spray for it,
Of
right?
course.
So one of the ones that is interesting, and immediately I thought of this because it combines a couple of different things, and it's wild, and it's sort of certainly more of a psychodrama realism-ish, not really real.
I'm so glad you
Is
thought of this one.
Yeah, Boxing Helena. If you're not familiar with it, it's not about BIID specifically, but I feel like it has a place here in our discussion because it is an interesting twist on the disorder. It's a movie from 1993, psychological thriller that dove into themes of obsession and control and intense violation of bodily autonomy. So the film centers on the relationship between Nick Cavanaugh, a successful but emotionally unstable surgeon, played by the late, great, incredibly talented Julian Sands, and Helena, played by who, Shiloh?
Sherilyn Fenn,
Sherilyn
Twin
Fenn
Peaks.
from
Twin
Twin Peaks,
Peaks.
right?
And this movie is directed by Jennifer Lynch, the daughter of David Lynch.
Which is so clearly like, David Lynch is just like out there. So
Oh, yeah.
clearly it's running in the
I've
family.
met Jennifer before. She is
Oh,
also
cool.
quite eccentric and great.
Neat. Okay. So Helena is played by Sherilyn Fenn, and she is a woman that he once loved extremely, and she repeatedly rejected him. So he has an unhealthy fixation on her that drives him to extremes. And the film explores this through the lens of BIID long before it was a topic of research because it includes forced amputation and sort of a version of Munchausen by proxy. So after Helena is involved in a car accident outside Nick's home, not unlike the movie Misery, he takes her in, and he initially like seems very invested in helping her recover, but his obsession with controlling her just spirals out of control. She rejects him again, even in her weakened state, and he makes the decision to amputate her legs, forcing her into a state of total physical dependency. And then later, he removes her arms, just renders her completely powerless. And it mirrors the dynamics of body integrity disorder. But in this case, he imposes the mutilation on Helena against her will, trying to reshape her body to match his own distorted vision of what their relationship should be. And in the film, his role as both captor and caretaker aligns with this because he not only physically incapacitates her, but also forces her into a state of dependency where he believes she has no choice but to rely on him for survival. What's really interesting is that, of course, he puts her in this box. He, like, she has no arms, she has no legs, but he dresses her almost like a goddess with like these
Right.
flowing, beautiful, and her hair is done perfectly and her makeup's done perfectly. And I mean, what the twist here is that no matter what he takes away from her, she still is in control. She absolutely does control him. And I don't want to give away the rest because I think it's a very interesting watch. It's not something
Yeah.
you would watch over and over again,
No.
but it's definitely a movie worth seeing. Very controversial at the time of its release because of the disturbing matter and this graphic portrayal of physical mutilation. And of course, viewers and critics alike were just really unsettled by the links that Nick goes to in controlling her. It was considered to be shock value. It's thought that it was a really good exploration of the psyche. It's interesting. I mean, it's 1993. We've seen a lot more graphic things that have become mainstream since then. So I
True.
be interesting. I think that if it was released today, it would be looked at very differently. The film's reception was largely negative, with a lot of people commenting on gender dynamics and violence. However, I think in my understanding of it through today's lens of my education and training, I think that it's a kind of a necessary conversation about gender
Yeah,
dynamics and
I
violence,
agree.
right? A lot of audiences were divided, but some people did appreciate it being bold and unsettling because it's psychological horror. And then others were like, I don't get this at all. It's too graphic, whatever. So it's become a huge cult movie with a lot of viewers going back to it for this exploration of control, identity, and obsession. So I recommend everybody watching it because it's very good.
Yeah, I probably shouldn't have watched it as like a junior high aged kid, but 1992 was like peak Twin Peaks era for me when it
True, but
came out.
but that's a good point because psychological horror is something that usually is a little bit beyond the average middle schooler or high schooler, maybe
For
once you get to
sure.
be,
For
yeah.
sure. But later, and then when you realize, like, if this had been directed by a man, I think there have been way more problematic things that we could say about it. The fact that it's Jennifer Lynch and she and Sherilyn Fenn are, incredibly close friends even to this day, that it was her project, that, it kind of speaks through the lens in which we can still have a lot of really interesting conversation today.
Now, interesting fact about the movie is that Sherilyn Fenn, who owns this role, I mean, she's so good in it, like in ways that like are so, it just the story takes a major twist, which is very interesting. But it was a huge controversy because Kim Basinger was supposed to play the role
Oh,
and it
interesting.
creeped her out so much she backed out, and there was a huge lawsuit that went on for years
I think I
about
do
how
remember
much
that now.
money they were saying it cost them because while
Yes.
Sherilyn Fenn was a major TV star, she was not a movie star, and this was right at the height of Kim Basinger's, like Kim
Yeah,
Basinger was like back-to-back movies there for a while where she was huge
totally.
star, most
Huh.
notably from LA Not So Confidential, right? Or LA
No, it's
Confidential. We don't
yes,
have our own movie yet, but we might, who
the
knows?
movie that everybody loves and that is our namesake, but I'm not a fan of.
Oh, I love it. I can't believe you don't like it. I love it.
It just doesn't hold up for me. There's a bunch of eye rolls, but the nostalgia is there. Okay, so just lastly, there is a documentary called Whole, WHOLE, from 2003 that explores individuals who feel the need to become amputees. They look at interviewing them, they interview psychiatrists, the loved ones around them, just to really get a good idea of what they're going through and how it's impacting people in their life. And the documentary is directed by filmmaker Jane Gilbert, really seeks to humanize those living with BIID while still looking at all these other aspects that we've talked about today, the psychological aspects, the ethical aspects, the medical implications, and what it means for the medical field in terms of starting to think about some of these disorders and how they will or will not address it. As a filmmaker, she was motivated by a fascination with the human psyche and the intersection of identity and body image. So it's interesting because they talk about several of the individuals in this documentary who are highlighted, and they refer to themselves as amputee wannabes. And, it brings up, how is this possibly perceived by other folks who are amputees who did not want to be amputees, right? I mean, we kind of talked about with our two case studies how they might be accepted by those communities or not, and especially
Right.
Jewel, who was taken in by, a blind community. But it's really interesting to look at the strong needs of these individuals from their own words and their own mouth, and how they are willing to take drastic steps to align their physical bodies with their mental image. And Gilbert interviews George Boyer, who shot off his own leg. And she interviews Kevin, who had his healthy leg amputated by a surgeon. She also interviews Dr. Michael First, the psychiatrist at Columbia that we talked about. And Gilbert's motivation to explore the subject stems, again, from her intense interest in how individuals just kind of navigate their identities when their internal reality clashes with societal norms and that intersection of medical ethics.
Which
So
is
kind
such
of
an
wraps
important
up
part of the
everything we've
Yeah, and
talked about.
that's a really important part of the conversation, going back to my squeamishness and my discomfort earlier in our narrative today, is the idea of, it's not about me.
Yeah.
It is
Yeah.
about this individual trying to find balance in their life, whether or not it's a neuropsychological disorder. So, we have people with neuropsych and psychiatric illnesses, and because they don't fit the parameters of what the culture accepts or expects, we expect them to mask, and we
Yeah.
expect them to take a whole bunch of medications to change their behaviors to match what the cultural norms are, right?
Oh,
So
yeah.
it's the same thing here, right? Or it's very close to it. And I think it requires patience and nuance, and the individuals such as myself, really doing some pick and shovel work about why I have these reactions that I do.
Certainly. Well, interesting stuff. I know it wasn't super crime heavy, but I guess we have ethics on the mind because we're going to be talking about ethics in our field at the Berkshires next weekend. So, again, we hope to see you guys there. If anyone wants to come last minute, just look at the code that's in our show notes. You can still get a discount on tickets if you're thinking about heading up there. But there's another heat wave here in Southern California, and we had another earthquake this morning. I didn't feel it, but it was centered out here towards me. I'm just like, fall foliage and good farm to table food, wear the sweaters and all the things. I'm here for it. I'm ready for
Which is
it.
so crazy, because you're
I
basically a
know.
gecko lizard. You just
I
love the heat so
know.
much, and
I
now you're
think,
sick of it.
yeah, I mean, the sunshine in Europe was awesome, but it was still like chilly at night. And I was like, ooh, okay, I am ready for this. Let's do it. So, yeah, that'll be awesome. All right, everyone. Well, we will see you next time on LA
Not so.
Confidential. Bye, guys. Take care.
Bye, folks.
We sincerely thank you for spending some time with us today. LA Not So Confidential is part of the Crawlspace Media Network in partnership with Glassbox Media. Each episode is hosted, produced, and written by Dr. Scott and Dr. Shiloh. Our post-production editing and sweetening magic is handled by the multi-talented Jason Usry of Ear Cult Productions.
The LA Not So Confidential theme entitled Cool Vibes Film Noir is composed and performed by the talented Kevin MacLeod. He graciously allows us to use his music via a Creative Commons attribution license, and you can check out all of Kevin's amazing work on YouTube.
All of the resources for each episode can be found on our website at la-not-so-confidential.com. You can find us on Instagram at LA Not So Podcast, on Twitter at LA Not So Pod, and on Facebook at LA Not So Confidential. Media inquiries and bookings are scheduled at alienistentertainment@gmail.com.
Please join us each month on Saturdays at 4 p.m. Pacific Standard Time for a live streaming and very interactive broadcast on YouTube entitled Behind the Couch. Stay tuned to all of our social media for our live streaming scheduling announcements.
Subscribe to LA Not So Confidential so you never miss a new episode. And lastly, we'd be honored if you joined our Patreon at patreon.com/LA Not So Podcast. With a subscription, you get an ad-free listening experience, and you'll be the first notified about upcoming live events, social gatherings, and super cool swag coming your way.
Thanks for listening, and join in with us next time on LA
Not So
Confidential. Bye, folks.